Hi, my name is Randall Flick. I'm an anesthesiologist and a pediatrician, associate professor of anesthesiology and pediatrics, and director of the Mayo Clinic Children's Center. I'm going to talk to you about anesthetic-related neurotoxicity in the young. This is an issue that has been of concern to anesthesiologists for more than a decade. The paper published in the journal Science by Chris Ikonomidou in 1999 really highlighted concern about the effect of anesthetics on the developing rodent brain. Subsequent to that, we published a paper at Mayo Clinic that looked at the effect of anesthetics on the frequency of learning disability in a population of children from Rochester, Minnesota. More recently, there have been two papers that have reduced some of the concern that's associated with this issue. One paper in Lancet by Andrew Davidson and his colleagues, and another in JAMA by Lena Sun and her colleagues at Columbia University. Both of these papers looked at anesthetic exposure in young children for relatively brief periods of time and showed no effect. So what is the issue that we're concerned about? The issue centers around the effects on the brain in association with exposure to GABA and NMD active agents. Essentially all anesthetic agents that we use in the operating room and that are used for sedation in intensive care units act at one or both of these receptors. And so we know that during the vulnerable period where the brain is rapidly growing, the so-called synaptogenic period, exposure to these agents can cause widespread and profound apoptotic neural injury. That injury affects virtually all areas of the brain, and it's quite specific to drug dose and duration. So different species respond differently to different doses and durations, as well as drugs. So what do we know from the animal studies? We know that the data are quite compelling. There are well over 1,000 studies that have examined this issue under carefully controlled conditions, multiple drugs, doses, and durations. The injury is quite consistent and reproducible, although again tends to be species specific. We know that it affects not only the histology of the brain, it also affects memory, learning, and behavior in animals, and including primates. We don't believe that the injury is permanent, at least in rodents. However, it appears to be in monkeys. We're not sure whether pain moderates the impact of anesthetic exposure, but best evidence would suggest that it does not. Now, no matter how we think about anesthetic agents in animals, we know that animals are not humans, and we can't compare them. We really have to look more closely at the human outcomes. So what do we know in humans? Well, we know a lot, but we don't know as much as we would like. We know that studies of brief exposures are mostly negative. Studies of repeated exposures under age 3 are nearly all positive. We know with a reasonable amount of confidence that comorbidity is not driving the outcome. In other words, sick children are at higher risk for anesthetic exposure and are at higher risk for a learning disability. One is associated but not causally so. We know that surgical exposure probably doesn't explain the outcome, but again, this is uncertain. The effect size that we see on learning is relatively modest. If there is a phenotype, it seems to center around speech and language. But very clearly, all the existing retrospective cohort studies are deeply flawed and don't constitute compelling evidence. So in summary, what do we know? Well, the words of Donald Rumsfeld, I think, are quite instructive here.
There are known knowns. There are things we know we know. We also know there are known unknowns. That is to say, we know there are some things we do not know. But there are also unknown unknowns. The ones we don't know, we don't know.
So the things we know are that retrospective studies really aren't able to create a causal link between anesthetic exposure and learning difficulties in children. We know that they are associated, and that association is important in and of itself. We also know that brief single anesthetics appear to be safe both from retrospective, prospective, and ambidirectional studies. The known unknowns here are the confounders that we try to account for but can't be sure we completely do so. Things like comorbidity, the effect of surgery, social status, other things that impact learning but may be confounding the relationship between anesthetic exposure and outcome. And then there are many things that we simply don't know to account for. And that residual confounding is the real problem that we are forced to account for as we think about future studies. And then finally, we have to be careful about the unintended consequences that go along with changes in anesthetic practice. This risk is a theoretic risk. We know that there are clear risks associated with anesthesia, the known risks of anesthesia. Again, this is theoretic. If we change practice based on theoretic risks, we may actually increase the risk to the child. Thank you, and I appreciate the opportunity to speak with you.